I call upon Dr. Rachna Chabria.
You're talking about USG guided saphenous nerve block for postoperative analgesia and arthroscopic knee surgeries, presenting a case series done at KM Hospital, Mumbai. Now, for arthroscopic knee surgery, it's considered to be a daycare surgery, minimal invasive, so the patient and the surgeons accept that there should be minimal complications with anesthesia. There should be no post-op pain, there should be no motor block, there should be no urinary retention. But post-op pain management is a major issue for discharge in the first 24 hours. So do we have a sensory nerve to block it? The nerve supplies the knee joint. So saphenous nerve is a pure sensory nerve which transmits pain, temperature and touch sensation from the knee joint. It also innervates the inner aspect of the lower leg and foot. So can it be provide post-operative analgesia? So we planned a study to assess the effect of saphenous nerve block with 20 ml of 0.25% bupivacaine in arthroscopic knee surgeries and post-operative pain in the following ways to assess the analgesic efficacy, the duration of action by using the visual analog scale, does it cause any side effects, and the requirement of the rescue analgesia. This is an interventional prospective assessor blinded study including patients with age between 18 to 50 years, AAC belonging to AAC 1 and 2 group, proceed for elective arthroscopic knee surgery, either an anterior ligament repair or a menisci repair. Patients who were excluded included contraindications to the nerve block like neuropathy, type 1 diabetes, coagulopathy, who did not understand the VAS score, who were allergic to local anesthetics belonging to AAC 3 and 4 class, and patients who refused to be a part of the study. 25 patients of AAC 1 class proceeded for lectomy surgery after taking adequate consent and starvation were wheeled into the theatre, the monitors attached, the IV access secured, they were given spinal anesthesia and sitting position using 25 gauge Quincke's needle, 2.5 cc, that is 12.5 mg of 0.5% bupivacaine heavy was injected intrathecally for spinal anesthesia. Then arthroscopy of the injured knee was performed. The patients were sedated with Medaz and fentanyl if required and given antiemetics ondansetron after the intrathecal injection. After the surgery, the patients were given USG guided saphenous nerve block. The patient was positioned supine, the thigh abducted, the leg externally rotated. The USG settings which was set was a depth of 3 to 5 centimeters using a linear transducer with a frequency of 5 to 15 hertz. The transducer was positioned in a transverse orientation on the anterior lateral thigh, approximately at the level of the mid-thigh, and then we start scanning from the mid-thigh towards the knee. This is the position of the probe, scanning from the mid-thigh towards the knee. The goal was to visualize the vastus medialis, the sartorius muscle, the saphenous nerve below the sartorius muscle in the subsartorial groove. Once the nerve is located, a 25 gauge Quincke's needle attached with a 10 cm extension with the 3-way and the 10 cc of each local anesthetic attached to the 3-way. Once the needle is inserted, it's inserted in plane approach from the lateral to the medial direction. And the goal was to place the needle under the sartorius muscle and inject the drug in allocates of 1 to 2 ml with negative heave aspiration, visualizing the hydrodissection and avoiding resistance to the injection. So once you start scanning, you see for the femur, then you localize the junction between the vastus medialis and the sartorius, and as you go distally below the sartorius in the subsartorial groove, you start injecting the drug. The block success was defined as a VAS score of less than 3 without need of additional analgesic dosings. Follow-up, the patients were all followed up in the recovery room for the VAS score at the interval of 2 hours for up to 12 hours. Injection paracetamol IV was given when the VAS score was more than 5. And if the patient had any side effects, it was also noted. All the patients were hemodynamically stable, none of them had nausea, vomiting or any episodes of hypertension. So saphenous nerve block provided good pain relief. The VAS was less than 4 at 2, 4 and 6 as in most of the patients. There was no pain relief in 2 patients. The mean duration of action from this judging for this was about 6 hours plus minus 1.5 hours. It did not show any of the significant side effects. Now, what options do we have to provide post-operative knee anesthesia for arthroscopic knee surgery? It's either done with GA, you may put an epidural or a nerve block, you give a spinal with an epidural anesthesia, or you give a spinal with a peripheral nerve block. Now, post-op pain we are really concerned with here. So, the epidural analgesia will give good analgesia, But it causes side effects like urinary retention, inherent spinal puncture, there could be retention of urine, there could be late onset of back pain. But in the daycare surgery, is it feasible to put a epidural catheter? Especially in our endal setup, can we put a catheter and send the patient home? It absolutely is not feasible. Spinal anesthesia, there is no post-op pain relief, and it causes side effects like prolonged recovery time, pruritus, urinary retention. This was proved by Murrell MF et al. When he compared spinal anesthesia, epidural and general anesthesia for outpatient knee arthroscopy, where he concluded that all the three modes of anesthesia are suitable for doing the surgery, but spinal anesthesia provides a prolonged recovery time to be discharged from the post-anesthesia care unit. Now the most useful thing is the regional nerve block. Now a study by Chakravarti et al. Which compared the regional nerve block to epidural anesthesia and daycare arthroscopy surgeries concluded that a regional anesthesia provides a shorter stay in the post-anesthesia care unit. It causes less post-operative rescue analgesia. It has less potential complications. The best patient comfort. The only problem is a little longer anesthesia induction time, but considering the advantage, it should be really considered. The regional nerve blocks that can be used is the femorosciatic nerve block, but again it causes significant motor weakness of the knee extensors and the flexors. Now the other option that we can be thinking about is the saphenous nerve block. It's a sensory nerve, and using the USG, it has a higher success rate than the landmark-based approach. A study by McCannum-Begg et al., which studies the feasibility and efficacy of ultrasound guided block on the saphenous nerve in the adductor canal, they have concluded if you use the USG machine, you can have a higher success rate than the landmark-based approach. It's a technically simple and a reliable procedure, and it helps in consistent nerve identification with block success. To start with the anatomy of the saphenous nerve is the longest branch of the femoral nerve, which divides from the mid-thigh, travels along the femoral artery, platform lateral to medial, coming on below the sartorius in the adductor canal. Then it divides to give supplies to the knee joint through the articular genu branches and the infrapatellar branch. It also supplies the medial part of the leg. Now, below in the sartorius lies the adductor canal. What else does the adductor canal contain? It contains the saphenous nerve. It also contains the vastus medialis and the two divisions of the obturator nerve. Now, when you are injecting significant amount of local anesthetics in the subtartorial groove, that is considering it to be saphenous nerve, if we are injecting significant volume, we also are bound to block the nerve to vastus medialis and the two divisions of the obturator nerve, which significantly supply the medial part of the knee joint, and so we are providing the analgesia for knee arthroscopies. The various approaches to block the saphenous nerve block, which have been studied by Benzon et al. And published in Anesthesiology Journal in 2005. The perifemoral, this is up here the inguinal ligament pair, the transsartorial or maybe block at the medial femoral condyle. Oh, okay. The transsartorial is supposed to be the best approach when you are using it for knee arthroscopy surgeries. And the future implications are it can be used for knee arthroplasties also, where we put in a catheter and provide sensory analgesia without causing side effects like the motor blockade and the side effects of the epidural.
A lot of people are studying what you are studying, which is good. So we need more data. Yeah, so we need more data for using it in knee surgeries, knee arthroplasties. Right. If you have to redo your study, how would you improve the methodology? Is there anything that you...
so I will use the limitation I didn't come time, I've finished my time out. I would use a controlled trial with some other analgesic comparing the saphenous nerve block, that the IV analgesics that we are using, the IV opioids that we are using. So there could be a controlled randomized study using more patients and assessing the motor blockade for the mobility of the patient. So post-operatively there are a few studies just assess the mobility of the patient. So where we are mainly targeting that there is no motor weakness, it's a pure sensory nerve. So the patient should be mobile with no pain. So
would you put the block before the spinal next time? Or would you continue?
So if we're putting the block before the spinal, we can do a prospective setup before the spinal and after the spinal. Then we perhaps use more adjuvants in the block so that we prolong the duration of the analgesia of the block. Otherwise, with the study we're just doing it lasts around 6 to 7 hours. After then we're just compromising the post-operative analgesia a little more less of fewer hours. So we put more adjuvants perhaps and then check if we are prolonging the analgesia with a single shot technique if we are using it. Or if you're giving it before anesthesia, put in a catheter and then give it.
If you do it before the spinal, perhaps you can check the success of the block before.
Yeah. Yeah, sir. Sorry? Okay. So that is why we didn't compare it without giving the block, because then you're denying analgesia to a patient without a block. So you obviously are giving other analgesics like IV opioids or paracetamol. So we're using other analgesic modes perhaps rather than the regional nerve block per se.